Hola, hola.
Poco a poco me los has pastoreado. Sí, necesita para ayudar. Muy bien. A ver si se me van sentando.
La presentación normalmente la suelen hacer ahí en la tribuna y luego ya lo de las preguntas lo hacen aquí abajo.
Aquí mismo. Explica aquí en el corner.
Yo no entiendo.
Es un poco informal. Okay, we move to the last and the scientific session, the last session of this Congress. And the first lecture is by Jaime Kulisevsky, and it's titled Apathy and Cognitive Impairment in Parkinson's Disease from St. Paul Hospital Research Institute. Jaime.
Okay, thank you very much for this invitation. I'm glad to be here. And this is yours. Is this one? Okay. Then in the next minutes, I will talk about cognitive impairment and apathy in Parkinson's disease, but I would like that we have progressed in the recognition of cognitive impairment in Parkinson's disease as own manifestation of the disease. We also have recognized the state of mild cognitive impairment in Parkinson's disease as a risk factor to evolve to dementia. And also, we have to acknowledge that not all patients evolve to dementia, and we are going to talk about this. But also, we are involved in an ongoing work to define different trajectories of cognitive decline, just to refine and individualize the prognosis of the patient that comes to our consultation and say, okay, you are saying that I am having mild cognitive impairment, then in the next 2 years I am going to become demented, and perhaps this is not true. And to find more appropriate treatments for this cognition. Then in the following slides, I aim to just to show you the importance of apathy in the context of this cognitive impairment, of apathy as a non-motor symptom, and the relationships of apathy with cognitive impairment and also with decision-making in non-demented patients with PD. And my final end is to postulate that apathy should be taken perhaps as a biomarker, both to define a different trajectory of cognitive impairment in Parkinson's disease and also as a selection criteria for potentiated drug trials of cognition in Parkinson's disease. First, it is rare or striking that this is a very recent cartoon for a very important person in Parkinson's disease, and then here we have mild cognitive impairment. Here we have dementia, but it seems that we have no apathy in the evolution of Parkinson's disease. And then, wow, I'm not sure whether this is the next one. Okay. We have two types of cognitive impairment in Parkinson's disease. We can define a domain-specific cognitive impairment that occurs in early stages of the disease and is characterized by relatively subtle deficits in specific cognitive areas, that is, recall memory, visuospatial processing, attention, concept formation. But this cognitive impairment is not extensive enough or severe enough to qualify as dementia, affects almost all PD patients, and also may qualify as mild cognitive impairment according to the new MDS criteria for mild cognitive impairment. And as I have said, it has a variable progression to full dementia. And then the other one that we also have criteria of the MDS Society and also may accomplish DSM-4 or DSM-5 criteria for dementia is severe and extensive, occurs late in PD, is strongly related to age, and is characterized by the addition of more Alzheimer's type signs of cognitive impairment, that is more posterior cortical deficits, as we can see, for instance, when we use specific scale separating this executive impairment that was said to be characteristic of Parkinson's disease, and now we acknowledge that the transition to dementia in Parkinson's disease is characterized at first by a progressive and steady decline in executive functions, such as verbal fluency or working memory, but of an abrupt decline later in the evolution of more posterior cortical tasks, such as clock drawing or confrontation naming, that are more Alzheimer's disease type of cognitive impairment. And perhaps this is strongly linked to other additional neuronal loss and problems with neurotransmission, in which cholinergic levels are very important, and are these alterations in cholinergic innervation that nowadays we know that is typical from the early stages in Parkinson's disease in many patients, is more related to the degree of cognitive impairment than to the years of evolution of the disease. That is, that not necessarily you will have this, but it is strongly related to the presence of cognitive impairment. And I don't know you to read all this busy slide, but in particular, from the neuroimaging point of view and also from an anatomical point of view, this extension of mild cognitive impairment to dementia is strongly linked to the alteration of temporoparietal regions in addition to frontal atrophy, and these that can be observed, for instance, in this very important study, could be followed by imaging and maybe also a biomarker in therapeutic studies of mild cognitive impairment for selecting samples with high risk of progression to dementia. That is, cognitive impairment may be characterized as the passage from a relatively subtle cognitive impairment with visual perceptual and attentional executive dysfunction to visual perceptual and attentional executive dementia, in which, for the first part of the slide, the contribution of dopaminergic deficits is very important, and for dementia there is a crucial contribution of a non-dopaminergic system. This may have many legs, and we can more or less separate the contribution of dopamine, that is partially responsible for the dysexecutive syndrome, noradrenaline that contribute to impaired mood and attention, serotonin to depressive mood, and acetylcholine explaining impairments in these more posterior cortical functions, but also, of course, the boundaries between these systems are not strictly defined. But what we have learned, and this is an important slide of an important study, is that besides age, that is the more important risk factor for the progression of cognitive impairment in Parkinson's disease, neuropsychological tasks that are of more posterior cortical basis, such as semantic fluency, inability to copy, explain the evolution to dementia, and patients with also predominant dysexecutive fluency, frontally based altered task, are not associated with dementia risk. That is, there may be different trajectories for this problem that we call mild cognitive impairment, that affects almost 1 every 4 patients that come to our clinics. And the main risk factor, as you can see, is older age at assessment and older age at disease onset. But this is a classification according to the Peterson criteria, and nowadays we have other types of classification. Perhaps Maricruz is going to talk about this. I'm not going to define these, but Importantly, it demands that besides cognitive impairment, subtle difficulties on complex functional tasks may be present. And here you have the different instruments that are recommended. But basically, this has two types of categorization. One is type 1, using only cognitive rating scales, and the other one is type 2, that is a more comprehensive examination of 5 domains using 2 tests for domain. Then, if the patient accomplishes these criteria, for instance, this is a recent study using these criteria, and you can see that the amount of patients that can be classified as mild cognitive impairment in incident patients without dementia of Parkinson's disease is impressive. It's more than 1 in 4, it's almost 1 in 2. But it also depends on how you use 2 standard deviation criteria, 1.5, and this is an ongoing work. And also there is a task force that is dealing with this. But the problem is that if we do not define which is the more malignant type of cognitive impairment, whether it is only these executive problems or multi-domain cognitive impairment, we are not going to select the correct sample for the future drug trials that are our goal in the next future. For instance, this is the first double-blind trial of using rivastigmine, that is, as you know, it's a cholinergic drug. But if we say, okay, cholinergic is very important for cognition, why rivastigmine is not running? And perhaps this is both not selecting an adequate sample just to show that some patients improve because they have cholinergic deficits and some patients do not, but also perhaps using not the correct instruments because they use it an Alzheimer's disease instrument. But this is just to show that it is very important to know which type of cognitive impairment has the patient, and also that this myriad of non-motor symptoms and also of psychiatric symptoms is very important to consider that does not occur in isolation. And then cognitive impairment occurs in conjunction with other non-motor symptoms, and of course we are going to deal with apathy in this talk. If we take a big sample of patients with Parkinson's disease, we can see that almost 50% has apathy. Then this is a very important problem, and this was not only showed by us, but also other studies. And also if you make a cluster of the different neuropsychiatric symptoms, one cluster is patients having apathy more than depression and anxiety. Another is depression more than anxiety, anxiety more than depression, and the final, not very large cluster of psychosis and psychomotor. But the more clear cluster is this, patients that have a lot of apathy, and in this sample, apathy is not presented in isolation. 41% of this non-demented sample also have cognitive impairment and dysexecutive impairment. That is, the two phenomena are presented or are presenting together. And what is apathy? Apathy refers to a set of behavioral, emotional, and cognitive features that are characterized by this reduced interest and participation in the main activities of daily life. The third day of a meeting of CIBERNED is some apathetic meeting, we can say, because there is a lack of initiative and a trend toward early withdrawal from initiated activities and also indifference. But apathy is a multidimensional problem in Parkinson's disease, and probably it requires a multidimensional approach because it has different components. One component is reward deficiency syndrome. Another is emotional distress. Both are linked. Another is executive function, because as we can see, or we are going to see, it is very linked to this executive impairment, and still there is an auto-activation deficit in apathy. Then there is a variable contribution of at least 4 major components of goal-directed behavior. And sometimes they occur in isolation, and you can characterize which is the patient with more auto-activation deficit, or but more frequently they occur in combination. And why care about apathy? We can be apathetic, as the cartoon that I showed to you. Apathy does not exist. Perhaps Lang was apathetic the day that made this cartoon. But 45% of these patients, that is a very big sample of patients, and this is a classic study now, has apathy, and apathy is the symptom with the highest impact on quality of life of this patient. Then there are also other studies showing that apathy is associated with greater functional impairment than depression and even than mild cognitive impairment. Then other examples, here you have a lot of neuropsychiatric symptoms and non-motor symptoms. 73% of patients has neuropsychiatric symptoms in this sample, but the only symptom with statistically significant association with ADL when you correct for motor symptoms is apathy. Then I expect that I have convinced you that apathy is important in Parkinson's disease. Then some examples of our work with apathy. One is what adds apathy to the cognitive behavioral profile of non-demented PD patients. Then we are going to examine the emotional affective component of apathy. And then we did this study, and we observed that facial emotional recognition is impaired in patients with Parkinson's disease who have isolated apathy. This is a sample that is not very easy to recruit, because patients that have apathy in isolation are not very frequent, and you have to be very strict with these criteria. And then these patients has no depression, has no cognitive impairment, but still they have a disruption of emotional affective processing that is highly selective, because it affects some emotions and not other, and in this case, negative emotions such as fear, anger, and sadness. That is, you know that emotion recognition is heavily dependent on the amygdala and the anterior cingulate cortex, and then we can conclude that these patients may have failures in this emotional component, and these differentiate them from non-apathetic patients. Then what adds apathy to the reward deficiency syndrome? Is there a reward deficiency syndrome in Parkinson's disease? As you know, an important problem today is impulse control disorder in patients with Parkinson's disease that is associated to the use of dopamine agonist. And then we make this study of decision-making and cognitive impairment in Parkinson's disease. This was not focused on apathy, but interestingly, what we observed was that there was an impaired decision-making in treated non-demented PD patients that didn't have depression or ICD. But the more cognitively preserved patients, that is, all patients had no cognitive impairment, but there are subtle differences that still are significant, in spite that they are not accomplishing dementia criteria of mild cognitive impairment. And there was a nice correlation with the Iowa gambling task with the MATIS, in the sense that the more cognitively preserved patients did worse on the Iowa gambling task. That is, here there is a relationship and a link between this, and a paradox also. This paradox can be explained by the extra doses of dopamine that levodopa or other cognitive or other dopaminergic agents are causing in different areas of the basal ganglia. As you know, the dorsolateral prefrontal cortex is depleted from dopamine, but the frontal limbic or the orbitofrontal is not so. And then if the more cognitively impaired patients have more denervation of the limbic system, then they are not going to show this deleterious effect that patients that with more cognitively preserved function and supposedly less denervation are showing, and this happens also with cognitive function that we are not going to use. But it is important to take this into account, because when we examine a different sample just focusing on apathy, and we can show that apathy is more than just executive dysfunction, and when using appropriate tools, apathy may differentiate patients with a subclinical pattern of cognitive impairment. And in this study, we showed that apathetic patients performed significantly worse in cognitive tests than non-apathetic patients, but still within normal ranges of the different scales, cognitive scales that we used for these patients. And surprisingly, or not so surprisingly, apathetic patients that did worse on executive function performed significantly better and within normal ranges in reward-related tasks. That is, you have to interpret this in the context of the previous slide, in the sense that perhaps apathetic patients has a different pattern of dopaminergic denervation with more dopaminergic or more extensive denervation of the mesolimbic circuits that preserve these patients to the overdose effect that we observe in more dopaminergic preserved patients. How we can examine this phenomenon from other point of view. Then we did this study just using a Gehring gambling task, that is, you make bets, and we observe how you react to losses. And this is a Gehring gambling task, and you can use this feedback-related negativity that is larger after unfavorable outcomes. It do not measure favorable but unfavorable outcomes. And normally, when you win heavily or when you lose importantly, then the next trial you have a more conservative response. And here is the feedback-related negativity in all the sample, and this is the overall patient. This is win, and this, the red one, is losses. And then we tested 20 apathetic patients, 20 non-apathetic, and 11 healthy controls. All were non-demented, non-depressed, and they are cognitively normal, within normal ranges, and there were no differences in any demographic variable, but only on apathy. And then we observed, this is the red one, is apathetic patients, and the other ones is control and non-apathetic patients. Then there is a significant difference, a significant diminution of the amplitude of the feedback-related negativity in response to these losses, only in apathetic patients. And then, if we enter and dissect this information, then the amplitude of this sample correlate or was found to be decreased in this new sample. And these findings strongly support the compromise of the mesocortical limbic dopaminergic pathway in the pathogenesis of apathy in PD. Here you have healthy controls, and this is the probability of making a risky choice in the next trial after you suffered a high lose or a high win. And then you observe that non-apathetic patients are risky-taking, and apathetic patients are very conservative. And okay, we can explain this, but Still, these are just, I am going to the last slides. This is an ongoing study, and we say, okay, we have to observe, besides neurophysiological and cognitive evidence, some structural evidence of whether apathetic patients are different from non-apathetic, and still we took 20 patients, or 18 patients, non-apathetic, 18 apathetic, and we studied the volumetric differences in the gray matter comparing these two samples of patients, and we say, okay, those regions that show significant differences will be defined as regions of interest and correlated with other clinical variables. And here you observe that, again, the samples only differ in apathy. And then we observed, this is in preparation, of course, a significant reduction of gray matter volume in a set of brain regions, the nucleus accumbens, inferior parietal lobe, left superior parietal gyrus, left inferior orbitofrontal cortex, insula, and right supplementary motor area. But interestingly, we observed significant correlations, and very strong one, between gray matter density in the nucleus accumbens, that is related with all these tasks, and cognitive performance as measured with the Mattis Dementia Rating Scale, for instance. And then, arriving to this point, I have to say to you that we are used to confound apathy with depression. Apathy is not depression. Apathy can be clearly separated from depression using the appropriate scales, but still there is a region of overlap that make the clinician not very prone to recognize apathy if we don't use correct scales. But it is important to recognize apathy because apathy and depression has different effects on cognitive performance. It's classic that the patient that is with depressive symptoms perform worse than a patient without depression. But interestingly, apathy has independent effects on executive function, memory, and verbal fluencies that affects daily function abilities. But this is not the case with depression. That is, overlapping symptoms are different. And more importantly, the occurrence of dementia in patients exhibiting apathy is increased by many folds against patients who has no apathy. And then apathy may herald cognitive decline. And of course, there are no pathological studies of apathetic patients in Parkinson's disease, and we don't know which is the place that differentiates these patients. But this is a very nice study for the group of Glenda Halliday, and then they observed that you need increased alpha-synuclein deposition and hippocampal dysfunction to become demented in a setting of more widespread degeneration of cortical dopaminergic and cholinergic pathways. And then the only big differences between demented and non-demented patients in this sample are an additional loss in the lateral part of A10 dopaminergic neurons, as well as cholinergic deficiency in the CH4 nucleus basalis neurons. And perhaps it is possible that the additional loss in this lateral part of A10 dopaminergic neurons, that we have some indirect evidence with the different paradigms that I have shown you, appears mandatory for the development of Parkinson's disease dementia and may also differentiate non-demented patients with and without apathy from the very beginning. Just to finalize, what about treatment? And there are very few formal approaches to treatment of apathy in Parkinson's disease. And as I've said to you, apathy is multidimensional, has many dimensions, and there are anecdotal reports of patients who improve with antidepressants, who improve with amphetamines, who improve with dopaminergic medication, but only 2 formal double-blind studies. First, we did this. We analyzed a big sample of patients comparing different treatments in well-matched patients. And the only interesting difference that we observed was that the percentage of patients with clinically relevant apathy was less in the group treated with dopamine agonists. Then the treatment with dopamine agonists may be influence the presence or the evolution of apathy in these patients, and this is in line with this double-blind study that has the bias that was only performed in patients after DBS, that their apathy that is presenting after DBS, that is not rare, improves in a double-blind fashion with dopaminergic agonist that is pirivedil that we have no here in our country, but the French people have. And the only one and completely different approach is with ribastigmine, showing that patients with moderate to severe apathy without dementia and depression may improve somehow with ribastigmine. And perhaps this is showing that there are different trajectories of apathy, that cholinergic influence is very important, dopaminergic influence is very important, and that both concurs not only to explain apathy, but to explain apathy plus cognitive impairment and a malignant trajectory towards cognitive impairment. My final slide is just to show that apathy should be added. We have to definitively place apathy in the roadmap of Parkinson's disease. And many thanks for your attention.
Thanks, Dr. Kulisevsky. We have time for a couple of quick questions.
Do you have any knowledge or on whether the MCI and other behavioral symptoms that you see as part of the Parkinson's are any different than the MCI in Alzheimer's or other neuropsychiatric? Do they have different underlying neurophysiological, neurochemical basis, or are they identical ones that are co-occurring? The reason for that is that if you were to treat that as an essential target for treatment, would all of them benefit? This becomes an important issue for therapy development, because if we target therapy development to Parkinson's, it will be very narrow, whereas if we develop therapy development towards MCI as a generic concept, or cognition as a generic, or depression, we would be taking care of large number of neurodegenerative disorders, because I think we're slicing the thing too thinly now, and it's working against us. I'd like to hear your thoughts on it.
Well, yeah, this is a very interesting question, not only from the pathophysiological point of view, but also for a regulatory point of view, because it is very important that we still not have the indication of treating mild cognitive impairment in any other context that will not be, and perhaps the next future will be, Parkinson's disease. And the problem to differentiate if mild cognitive impairment of Parkinson's disease is different from Alzheimer's disease stands from the very beginning. In Alzheimer's disease, the main problem is to identify among the normal and general population who are the ones that exhibit symptoms of cognitive deterioration that may impact on their functionality. And these are perhaps memory problems just following the course of deterioration in Alzheimer's disease. But you have to deal with the general population, and you have the problems that many subjects that you have identified as mild cognitive impairment, then some ones evolve to Alzheimer's disease, others stabilize, and still other improves. And then this implies that we have only with cognition is not enough. In Parkinson's disease, the problem is absolutely different, because you have a disease that per se has cognitive problems. And then this population is at risk of exhibiting dementia. 6 times more frequent dementia in the general population if you have Parkinson's disease. And then this is the risk factor, and you have confronted with the disease that by their own has cognitive problems. Then, these cognitive problems are mainly linked in the early phases of the disease to dopaminergic deficit. And then these are mainly dysexecutive problems. Perhaps this kind of mild cognitive impairment that still can accomplish the criteria of the MCI task force just on this executive type of mild cognitive impairment is not the one that will evolve to dementia, as has been showed by the Williams-Gray study and other studies, but is the more multidimensional patient with multidimensional problems with memory that is not only recall memory, drawing, other more posterior, more Alzheimer's type, that is the one who is going to evolve. And then we still need to validate the new criteria, but the context of the problem is entirely different. And this was very clear when you go to the FDA, and I did this with Michael J. Fox just to propose a candidate drug for mild cognitive impairment. And then their first response was, mild cognitive impairment, we are not going to deal with this concept because this is very dangerous and we are not very prone to approve a drug for mild cognitive impairment. But when we argued that Parkinson's disease was absolutely different, they accepted that this is a completely different concept of the concept of mild cognitive impairment in the general population. Then the answer is really large, but is yes, they are different.
Okay, we are a little out of time, and then I'm going to do very...
Out of time because we began late. It's not, right. Don't put the blame on me.
And then I will try to do a relative quick question, and something that I learn a lot when I listen to you people working in other areas. And you said that the apathy, that is very important, I know now that it's very important in Parkinson's disease, is related with changes in the anterior cingulated cortex. Following the comment of Professor Kachaturian, he tried to look for a relation between a change in a structure, a lack of function. And in this case, you indicate that this change in the structure could be the anterior cingulated cortex, but it's now very common in Alzheimer's disease and in mild cognitive impairment that is the posterior cingulate cortex, the one that could play perhaps a role in this defect. My question is, do you think that there is any connection between the anterior and posterior, or could be some relation between these two parts in the cortex, in the cingulated cortex?
Well, this is a really interesting question that perhaps we need some 20 extra minutes to answer. But the approach that we did, of course, the last study is ongoing, and we have just wanted to show you that we are dealing with this. But the first concept is that you do not need structural changes for the things not running in a proper way, because only the deposition of alpha-synuclein in different regions explain a dysfunction, and then you don't need to wait for the neuronal loss to have a dysfunction. And our main proposal is that apathetic patients has a different denervation of the mesolimbic mesocortical pathway. Whether it implies or not the anterior or the posterior cingulate will be interesting to know and to make further studies. And we wish to link this extra dysfunction with the more malignant evolution of these patients towards dementia or cognitive impairment, and to link these findings with the pathological findings in the sense that you need both to go to dementia, PD-related pathological alterations, and perhaps also AD-related pathological alterations. Then, at the final end, I'm not sure whether we are going to have a select sample of apathetic patients to go to autopsy, but my guess is that both regions are not running properly. Perhaps one is more involved in dopaminergic deficit, the other one more structural, but related to alpha-synuclein deposition. And then we will need at least not a single approach to treat these patients. We will need dopaminergic therapy, we will need to reinforce the cholinergic transmission, of course we will need anti-alpha-synuclein deposition drugs, because with only the accumulation of alpha-synuclein, your circuits are not running properly.
Okay, we have no more time for more questions. We need to move on to the next lecture by Cruz Rodríguez Oroz from BioDonostia Institute, and is titled Parkinson's Disease in Advanced Stage.
Okay, so good morning. First of all, I'd like to thank the organizers for inviting me to give this lecture. And I'm going to talk about Parkinson's disease in advanced stages. I have to say that when I was invited to give this lecture and I proposed this title, I didn't know that Jaime Kulisevsky was going to talk just before me, and the topic was going to be cognitive impairment in Parkinson's disease. That is one of the major aspects we face in advanced Parkinson's disease. So I've modified a bit my presentation, and I'm going to talk about cognitive impairment and dementia, because it's almost impossible to talk about advanced Parkinson's disease without touching this important aspect. But I'm going to talk also about other features that are very important in our patients with advanced Parkinson's disease. So, having said that, the talk is going to have 3 parts. In the first part, I'm going to talk about what we think that today is advanced Parkinson's disease, because this is a dynamic concept. Advanced Parkinson's disease is not nowadays the same that advanced Parkinson's disease only 2 decades ago. And then I'm going to focus on 2 major aspects, 2 key features that have patients with advanced Parkinson's disease and that affect in a very, very relevant way their quality of life, that are freezing of gait and cognitive impairment and dementia. So, as you know, Parkinson's disease is characterized by the degeneration of the dopaminergic neurons of the substantia nigra and the lack of dopaminergic innervation in the striatum. And that leads to a number of alterations in the motor circuit of the basal ganglia and the development of the cardinal motor signs that are tremor, rigidity, and akinesia. Everyone knows that this is typical in Parkinson's disease, and this is why we diagnose our patients with Parkinson's disease. So these are the first symptoms, the first signs we identify in the clinical Parkinson's disease in our patients. And this is related, this dopaminergic degeneration, to the presence of Lewy bodies, as all you know. But as the disease progresses, there is a number of changes that are not only in the dopaminergic system. Of course, Parkinson's disease is characterized by a higher severity of the motor signs as the disease progresses that are due to the continuous dopaminergic degeneration, but also there are other neurotransmission systems that degenerate since the beginning of the disease, but as the disease progresses, the degeneration in these neurotransmission systems is also greater. As Jaime mentioned, there are a number of noradrenergic deficits, serotonergic deficits, and cholinergic deficits that are going to be very relevant And in advanced Parkinson's disease, all these deficits are definitely greater than at the beginning of the disease, and they account for a number of symptoms, mainly non-motor symptoms, as Jaime mentioned, apathy, depression, etc., that I'm not going to talk about. But in addition to these neurotransmission deficits, these patients in advanced stages have a spreading of the Lewy body pathology. At the beginning, you know that Lewy bodies are restricted to the brainstem and other subcortical structures, but as the disease progresses, Lewy body spreads to the amygdala and to the cortex, to the neocortex, following the Braak stages, not in all, but in many patients, let's say that in a good number of patients. But not only there is this pathology, also we have this Alzheimer's disease pathology, neurofibrillary tangles, and beta amyloid plaques. So we have this pathological progression in Parkinson's disease, and of course the evolution of Parkinson's disease in relation to the underlying pathology is going to have different stages. At the beginning, as I said, the cardinal motor signs are the major features of Parkinson's disease that are mainly due to the dopaminergic degeneration and easy to treat. With dopaminergic reposition, we are going to improve, very importantly, these motor signs, and patients are going to have a practically normal life, and the quality of life is really, really improved. But after 5-10 years of evolution, this stable improvement that our patients get with dopaminergic replacement therapy is going to suffer a number of problems, and patients start to have what we call complications, motor complications, that is fluctuations in their motor state in relation to the intake of the dopaminergic drugs, but also dyskinesias, that is involuntary movements that they can't control when they are under the effect of the levodopa treatments. And this is a very severe problem that our patients have after a number of years of dopaminergic degeneration and chronic dopaminergic replacement therapy. And that is what was called advanced Parkinson's disease just 2 decades ago. But at that time, also, the surgical treatment with deep brain stimulation of basal ganglia, mainly the subthalamic nucleus, but also the globus pallidus internus, changed completely the scenario of Parkinson's disease and have changed what we now call advanced Parkinson's disease. Why? Because this is what a patient with Parkinson's disease without levodopa treatment and without the stimulation looks alike. You can see that this is a very bradykinetic patient. You can see problems in gait. You can see the rest tremor he has in his right arm, a lot of motor signs, easy to define that this patient has Parkinson's disease. This patient has more than 10 years of evolution of the disease, and these are the major problems. This is the off condition without treatment, without drugs, without DBS. The deep brain stimulation is switched off at this time. But when we start stimulation, you can see here, the change is dramatic. So this is only under the effect of deep brain stimulation of the subthalamic nucleus. And this is a continuous state. It doesn't matter if the patient has taken levodopa or not. This is a continuous state. So as you can see, the motor fluctuations and dyskinesias are completely abolished in these patients or very significantly reduced, and the quality of life and the problems these patients had are solved. So we goes to the next scenario, that is that we are attending these patients years after surgery, and we are facing a new phase of the disease. That is what we now call advanced Parkinson's disease, and that is mainly psychiatric complications, visual hallucinations, cognitive impairment and dementia, postural instability and falls, and freezing of gait, that are not related to the dopaminergic deficiency, are mostly related to cholinergic deficiency, other neurotransmission systems, and extensive proteinopathy, Lewy body, and Alzheimer's disease. And all these abnormalities lead to gray matter dysfunction and degeneration, as we can see in several studies, and some of them I will show you. Of course, there are other features in advanced Parkinson's disease, such as autonomic problems, count of cornea, fixed postures, muscle wasting, sleep disturbances, depression, but I'm going to focus today in freezing of gait and cognitive impairment and dementia. So starting with gait disturbances in Parkinson's disease, there are two major phenotypes of gait problems in Parkinson's disease. The first phenotype in the early stages of the disease is a hypokinetic pattern of gait. And this pattern is a short-stepped, shuffling gait with reduced velocity and without proper movement of the arms, that responds very well to the dopaminergic treatment because it's mainly due to bradykinesia, okay? It improves very well with the dopaminergic treatment and patients are able to walk normally. But as the disease progresses, patients start to have this other pattern. This is freezing of gait. The patient has difficulties initiating and maintaining gait. The feet are glued to the ground. They have this incapacity to start movement and to maintain movement. And this doesn't respond very well to levodopa or to deep brain stimulation. At the beginning of this phenomenon, in the early stage of this problem, there is an improvement with drugs, with dopaminergic treatment, but as the disease progresses, the improvement of this phenotype is not longer, is not sustained, okay? So this is a problem we have in our patients, and we don't know really how to solve. I have to say that this problem doesn't correlate, freezing of gait doesn't correlate with rigidity and with bradykinesia. It's a different motor sign and doesn't respond to levodopa, as I mentioned. So probably freezing of gait is a distinct motor feature of Parkinson's disease with a different pathophysiology. I don't know what is going on here. Okay. So how can we understand better the pathophysiology of this problem? We have several approaches, of course, imaging approaches, as I will show you later, but also neurophysiological approaches. And neurophysiological approaches are more restricted. It's more difficult to study neurophysiologically this problem because we don't have access to the brain of these patients. We can study the legs of this patient, that is, whose legs are glued to the ground. But taking advantage of deep brain stimulation, we are able to study the activity of the subthalamic nucleus when we have the electrode for chronic stimulation, for deep brain stimulation, implanted in the subthalamic nucleus. Because we can make these bipolar derivations between two consecutive contacts, and we can record the neuronal activity of the neurons of the subthalamic nucleus surrounding this area. So we have 3 channels recording the neuronal activity of the subthalamic nucleus. And simultaneously, we can record the EEG activity in the primary motor cortex, but also in the premotor cortex. So we studied patients with and without freezing of gait through this method. And one important thing is that patients with Parkinson's disease, when they are in the off state, have mainly a beta band activity. The oscillatory activity that predominates in the off state is the beta band activity. But this beta band that you can see here, this is the off recording, the beta band, has 2 components, a low frequency and a high frequency beta band. The low frequency improves, is almost suppressed with dopaminergic treatment, while the high frequency is not modified with dopaminergic therapy or is very mildly modified. And in addition, low beta activity correlates with the severity of rigidity and bradykinesia. So this is an activity that is almost suppressed with dopaminergic therapy and correlates with motor signs that improve with dopaminergic therapy, whereas this activity, that is the beta high, the high frequency of the beta band, doesn't correlate with rigidity and bradykinesia and is not suppressed with dopaminergic therapy. So we thought that probably freezing of gait might be related to this high beta activity. And we studied specifically these 2 activities of the beta band, these 2 frequencies of the beta band in patients with freezing and without freezing of gait that had been operated with subthalamic stimulation. There was no difference in the lower beta activity. The one that is related to rigidity and bradykinesia was the same in both groups, but there was this difference in the high beta activity. Patients with freezing of gait have a higher power in this high beta activity than patients without freezing of gait. Those patients still had a degree of response in freezing of gait with dopaminergic therapy. And when they respond to dopaminergic therapy and there is a reduction in the severity of freezing of gait, there is also a reduction in the power of the high beta band activity. In contrast, patients without freezing of gait don't change their power in the high beta activity, and of course it is different between the two groups of patients. So there was this difference in the high beta activity in patients with and without freezing of gait, and we studied also if there was a coherence between this high beta activity in the subthalamic nucleus and the high beta activity recorded simultaneously in the EEG. This oscillatory activity is coherent, what is taking place at the same time in two different structures, and we analyzed if there was this coherence and in which electrode this coherence was maximal. And we saw that high beta activity was coherent with the activity recorded only in the electrode in the part in the C set that is here in the middle part of in the medial part of the primary motor area that represents the leg area, but also records activity coming from the supplementary motor area, premotor aspects, and the cingulus that is a cognitive element, as Jaime said, related with apathy, with attention, with the executive function, and with this kind of cognitive functions. In contrast, the low beta activity that we recorded in the subthalamic nucleus and that was related with rigidity and bradykinesia was coherent with the low beta activity recorded in this area, that is in the lateral part of the primary motor cortex that are the regions representing the arm. One important thing is that executive function is very related with gait in normal people. If you have an overload in executive function, you are not going to be able to walk as quick or as precisely as you walk without this overload in the executive function. And there are many diseases in which frontal lobe dysfunction occurs with this executive syndrome and with freezing of gait. And it's known that patients with Parkinson's disease and freezing of gait usually have a dysexecutive function. So we saw if these patients also had this problem, and it was the case. Patients with freezing of gait have worse executive function in two tests of executive function. Very importantly, in semantic fluency test, that, as you remember, was one of the predictors of dementia in the Williams-Gray study. That is a very classical and important study. So we found that not only these patients were different from the cognitive point of view only in the executive syndrome, they don't have any other difference in the cognitive domains, but also this dysfunction correlated with the high beta power, with the power in the high beta band. Okay? So this is important because we have a relationship between an executive function and a cognitive function, a motor function, both in advanced Parkinson's disease, both interrelated in this specific problem. What are the imaging studies telling us about freezing of gait? Okay, if we look to the brain matter atrophy, to the gray matter atrophy and to the DTI studies, there are some studies showing that there is an atrophy in the frontal and parietal cortex, interestingly in the left side. This is going back to the laterality that yesterday we saw for the MCI patients in the Vallecas study. And there was also a correlation between the atrophy in these regions and the severity of freezing of gait as evaluated with a typical scale of freezing of gait. Not only in the cortex there is this atrophy, also in the PPN, the pedunculopontine nucleus, that belongs to the mesencephalic locomotor region, that is a key structure in the automatic gait, there is an atrophy. And also, DTI has shown that there is a reduction in the white matter density of fibers that are arising from the right pedunculopontine nucleus. So there are structural alterations in regions that are involved in gait, frontal regions, parietal regions, but also in the mesencephalic locomotor region, not only in gray matter, but also in structural connectivity. Going to functional studies, there are some interesting functional studies that has been conducted in these patients, and this is an interesting study that using a virtual imaging paradigm, patients have to arrest or have to walk while they are being scanned. they have been scanned, and there is a bold activation and deactivation during the contrast of motor arrest and walking in these patients. You can see here in blue the areas that are deactivated, that are the caudate, basal ganglia, okay? And the sensory motor cortex. You know that the caudate is the main, is the striatal structure receiving projections from the frontal areas, not the primary motor cortex, but the anterior areas of the frontal cortex. And there is an increase in connectivity in the left dorsolateral prefrontal cortex and posterior parietal region and the insula, probably as a compensation of this problem that patients have to initiate and maintain gait. They try to override this problem, activating some parallel circuits, and it is known that based on external clues, patients with freezing of gait can improve freezing of gait, probably using these alternative pathways. Sorry. Again, this study also shows that there is an activation of the mesencephalic locomotor region in these patients. So the conclusion of this first part is that patients with freezing of gait have maximal coherence to signals taking place at the same time in different regions. So patients with freezing of gait have maximal coherence in the high beta activity, not in the low, in the high beta activity between the subthalamic nucleus and the midline cortex that takes the neuronal activity of the supplementary motor area, the leg area of the primary motor cortex, and the cingulus, which in turn correlates with executive function. High beta activity along the motor and also cognitive, the cingulus, frontal cortex basal ganglia network participates in the pathophysiology of freezing of gait and is also involved in the modulation of executive function and the combination of the two problems. Structural and functional changes in the frontal and parietal cortex and also in the PPN and basal ganglia identified in MRI studies support the physiological observation indicating a dysfunction of these pathways. So corticostriatal, PPN, and basal ganglia dysfunction all together interacting in different functional ways in patients with freezing of gait. And going back to what Jaime said, not necessarily you need structural or big structural changes to modify the function and the pattern of activity of circuits and structures, and that can lead to abnormal movement and abnormal non-movement symptoms. It's very well known that there is clearly functional differences in the on and off motor state in the motor circuit. So this is in line with these problems, but in other oscillatory activity. Jumping to mild cognitive impairment and dementia, I'm not going to explain what mild cognitive impairment is. You all know what it is. And as you know also, it's a risk factor for dementia in Parkinson's disease. There are a few longitudinal studies in patients with PD and MCI, but using the task force criteria that I'm not going to explain because this is a consensus for the criteria we are going to use when we are defining mild cognitive impairment, we have undertaken this study, and it's longitudinal study with patients with normal cognition and patients with mild cognitive impairment, re-evaluated 3.5 years after the first examination. And we have seen that 42% of patients with mild cognitive impairment develop dementia, while only 4% of patients with normal cognition develop dementia. This is in line with several other studies, so definitely mild cognitive impairment is a risk factor. It doesn't mean that all patients are going to have dementia, but it's a risk factor, and we have to dip into what mild cognitive impairment is and the pathophysiological mechanism underlying mild cognitive impairment. So we have studied this through FDG PET to see the metabolism in the brain of these patients, and also through MRI to see the gray matter density, and we have compared the hypometabolism and the gray matter atrophy these patients with mild cognitive impairment have and patients with dementia have. Focusing on the PET studies, the FDG uptake, we have seen that patients with dementia in comparison with control subjects have this abnormal FDG uptake, this hypometabolism in the parietal, temporal, occipital cortex, and also in the frontal lobe. Patients with mild cognitive impairment compared with controls have, of course, a big difference in the areas we detect. There are hypometabolism in restricted areas in the angular gyrus, in the occipital cortex, and in small areas of the temporal and the frontal lobe. But when we compare patients with mild cognitive impairment and dementia to see where are the difference in hypometabolism between these two groups of patients, we observed that in patients with dementia, hypometabolism is greater than in patients with mild cognitive impairment, but in the posterior territories, in the parietal cortex and in the occipital cortex and this posterior part of the temporal cortex, in line with cognitive studies that are telling us that let's say the point where mild cognitive impairment converts to dementia is when important posterior cortical deficits are taking place. But if we compare the hypometabolism of these patients with the atrophy of these patients, we can see the following. Because the question is, hypometabolism is a reduction of function, okay? But is this due to atrophy, or there is something else in hypometabolism? We can say that hypometabolism and atrophy is the same. Those regions that are hypometabolic are because they are atrophic, there is a loss of gray matter density, or hypometabolism or something else than atrophy. So this is the figure of the hypometabolism in patients with dementia. You have seen it before. And this is the figure for atrophy in patients with dementia. You can see that hypometabolism is higher than atrophy. So if we compare directly hypometabolism and atrophy, we see that hypometabolism is higher than atrophy, exceeds atrophy in these regions, whereas atrophy only exceeds hypometabolism in a tiny region of the temporal lobe. So definitely hypometabolism doesn't coincide with atrophy areas all the time. There are some areas where they coincide, but there are some areas where they don't coincide. The patient doesn't have atrophy, but has hypometabolism. When we do this in patients with mild cognitive impairment, we have here the hypometabolism, as I showed you before, and here we have the atrophy pattern. Again, we can see that these patients have less atrophy than hypometabolism, and of course, both of them are lower in patients with mild cognitive impairment than in patients with dementia. But when we compare in patients with mild cognitive impairment hypometabolism atrophy for the same purpose, to see if every region of hypometabolism coincides with regions of atrophy or there is something else, we see that hypometabolism was higher than atrophy, exceeds atrophy in these regions. So atrophy is much less than the regions where these patients have hypometabolism without atrophy. And going into detail in the major findings, if we see to the areas where patients with mild cognitive impairment have only hypometabolism, and you see the regions where patients with dementia have atrophy, you can find some similarities. This region with hypometabolism only MMCI has atrophy in patients with dementia. This region with hypometabolism has atrophy in patients with dementia. This region the same. And surrounding these regions of atrophy, there are hypometabolism in patients with dementia. So if we merge the images of hypometabolism and the images of atrophy in patients with MCI and dementia, we can see that what is only hypometabolism in mild cognitive impairment transforms in a core of atrophy in patients with dementia that is surrounded by a big area of hypometabolism. Here we have the same, a small atrophy and hypometabolism, higher atrophy, but a big region of hypometabolism surrounding the core of atrophy. So our hypothesis is that hypometabolic areas observed in the group with mild cognitive impairment have been replaced by atrophy in patients with dementia, which at the same time are surrounded by extensive zones of hypometabolism. This is spreading, the hypometabolism is spreading, and probably with time, these regions of hypometabolism will become atrophic. So to conclude, FDG PET studies clearly says only function that dementia respect to MCI in PD is characterized by cerebral hypometabolism in the parieto-occipital-temporal junction and less in frontal lobes, according with the cognitive deficits we have in those patients that are characterized by dementia in contrast to patients with MCI. But when we compare the two techniques, FDG and MRI, in PD-MCI patients, what predominates is a hypometabolic state, a dysfunctional state. There are few areas of atrophy, whereas in PDD patients, these hypometabolic areas observed in the group of MCI have been replaced by areas of atrophy which were surrounded by extensive areas of hypometabolism. So our hypothesis is that hypometabolism and atrophy might represent two steps of the same process, initiated with a reduction of cortical glucose intake and evolving towards a decrease in gray matter volume, which appears to expand in an exocentric pattern as cognitive decline progresses, mimicking the concept of ischemic penumbra for stroke. And I think that this is a good thing, because this is an opportunity to treat our patients. If there is something that is leading to functional problems, but still they don't have lost the volume, we have a window, a time window, to improve this functional problem they have and to avoid the progression to a definitive structural change that would be atrophy. So I think this is the last slide. This is the group. Okay, so thank you very much for your attention.
Thank you, Maricruz. It's time for questions, comments.
Only a brief comment, and I'm sorry because I was leaving and going out. But at the beginning you told us, and at the end too, that there is some changes in gray matter volume when you are looking to specific zones. Then usually when I listen to changes in gray matter, the decrease, I am thinking in dendrites. And when I am thinking in dendrites, I am thinking in synapses. Do you think that is like in another cases a real synaptopathy or Parkinson's disease, and which kind of mainly the synapses that could be involved?
Which kind of?
Of synaptic transmission is the one that is involved.
Yeah, that's a great question, because this is precisely this is our hypothesis, and this is how we finish our discussion in that Brain publication. And actually is the main topic of a project I've been granted to analyze this component. And I don't know exactly, but I think that this must be called glutamatergic neurons, cortical glutamatergic neurons. That would be my hypothesis. But because it's the major predominant neurons to connect, but I cannot tell which is. And we are trying to test that, as I said, but it's only a hypothesis. I would say that it's glutamatergic transmission which is failing in these patients. There are some studies saying that in patients with Lewy body disease, there is a failure in the transmission of in the release of glutamatergic vesicles at the beginning of the disease, even before the aggregates of alpha-synuclease appears in the cell, just when the aggregates are on the dendrites. So I think that could be glutamatergic based on that study and on the general thinking.
Thank you, because it's fine, because in the second slide of Dr. Kulisevsky, I think that he put that the glutamatergic involvement in Parkinson's disease with a very big interrogation mark. And then you solve us the problem. And then we can perhaps remove in the future that interrogation mark after.
Yeah, I think that still there are few people looking at glutamatergic system, but I think that is going to be important also in the cognitive deficits and in other alterations that we can see in the advanced stages, in the late phases of the disease.
Okay, thank you.
have a question, Mike Cruz. There is any neuropathological data about the underlying neuropathology in these different states, the hypometabolism and on atrophy?
There are only hypometabolism and atrophy. Say it again, the question?
Yes, there is neuropathological difference in this area, in different states, hypometabolism and...
Not at all.
Not.
No, because when you have a patient with dementia and you have a patient with mild cognitive impairment, they have both hypometabolism and atrophy. And even if you focus on mild cognitive impairment, you can say that, okay, these patients could have more hypometabolism than atrophy. You never know. And there are only 2 studies, pathological studies, and the pathology they have found is similar to the one that has been found with dementia. The problem mainly is that if you keep the dysfunction that this pathological inclusions drives, probably you get the synaptic dysfunction gets at the end leads at the end to a structural dysfunction.
Yeah, okay. More question, Justo?
Thank you very much, Maricruz. I would like to ask you about what is the evidence for synucleinopathy versus tauopathy in PD dementia?
I would say tauopathy and beta amyloidopathy, because brain studies show us that both amyloid plaques and neurofibrillary tangles are very abundant in the brains of patients with dementia. And there are studies saying that it's more important the presence of cortical Lewy body pathology, and even the density of Lewy body pathology correlates in certain areas in the temporal lobe, for instance, correlate with the severity of cognitive impairment. There are some studies. Some others saying that the major point could be the addition of neurofibrillary tangles and beta amyloid plaques. But still, I think that it's a matter of controversy, and probably the point is that also Jaime said there is not a unique phenotype of dementia in Parkinson's disease. Probably we are facing different types of mild cognitive impairment. We are facing different types of dementia. Some of them can have more cholinergic deficit. Some may have more Alzheimer's disease pathology. And I think that this is a confusion that has to be clarified with patients very well studied during their lives, and finally having the pathological study of those patients. I don't see any other way to clarify this point.
Okay, we move to the last one, lecture by Mercé Boada. It's titled Healthy Brain Initiative from Fundació Barcelona.
Good afternoon. Thank you much for inviting me to the CIIEN institution. I'm glad to share the first results from this study. And this study is focused, as in the next slides I explain you indeed. This study is focused in another aspect that was talked Jaime and Maria Cruz here. They are talking about mild cognitive impairment. It's moving to the left from dementia to mild cognitive impairment, and talk about it. It's very complex to define mild cognitive impairment, even in the clinical features, even though in the neuroimaging aspects and in neurophysiology. And we are talking in another aspect more left than mild cognitive impairment, is subjective memory decline. A ver, esto. My talk is divided and to define or to talk about what is the new concept of subjective cognitive decline, and could be if it exists, and we are agree that it exists, because times ago we are a big mark about its mild cognitive impairment has an important and relevant in development to Alzheimer's disease, even though in Alzheimer's disease, for Alzheimer's disease patient and for Parkinson's disease. Another is to introduce the FACEHBI study, to talk about the methodology, the flow chart, and to show you the first results in the very small sample from 17 subjects that we are finished all the neuroimaging study, and I want to talk with you the final comments, not the conclusions, only the final comments. One, subjective memory decline could be a new clinical phenotype, and perhaps it's necessary to detect near in the nothingness, because we are in nowhere sometimes when we're talking about the subjective memory complaint. Subjective memory complaints or subjective cognitive decline, the framework prefer to use this name to define a self-experience to decline in the cognitive functions, but it's completely different, and it's to need to be absence of the objective cognitive impairment. Cross-sectional studies have shown an increase of the possibility of the AD biomarkers. That is the relevance of this new phenotype, and it's necessary to know if AD biomarkers in subjective decline, it's similar to the controls or it's different to the Alzheimer's disease. In the most longitudinal study have found an increase of risk of developing cognitive impairment and dementia in individuals with CFD. And if you come to confirm this one, could be subjective cognitive decline could be considered as a risk factor for developing Alzheimer's disease in a very, very preclinical stage, or subjective memory decline may well be a suitable target to better identify early phenomena at the presence of the preclinical Alzheimer's disease. What is important to define preclinical Alzheimer's disease? As you know very well, there are at the present the two important clinical trials that want to involve preclinical Alzheimer's disease to be treated with the same drugs and the same components as Alzheimer's disease to prevent or to stop the disease. And to define this kind of subpopulation, and we think that it could be very important in the progress and to understand a little more about Alzheimer's disease. Let me show you only three papers. It's led by Frances is the first one, and the Frances is the first one. It's working with a populational study with the group of general practitioners in Germany, and they collect general population like Vallecas population. It's more or less 75 years, and follow this one, and they introduce this study with three questions. One, do you have memory problems? No. Second one, if you have memory problems, you're worried. One said, yes, I am worried for these memory problems. And another said, no. If you can see here, maybe it's here. If you can see here, it's different supervision from the population that said, I don't have memory complaints, and the difference from that is worrying for the memory complaints, they fall more in my cognitive impairment and dementia than the other, only with these three elemental questions. The other is based on these findings, on the results, the group of subjective cognitive decline initiatives define and conceptual framework in order to use and to normalize the introduction and to define cognitive memory complaints. And the other, in the top, this is a beautiful meta-analysis, really a beautiful meta-analysis. It's defined the reach of dementia to mild cognitive impairment in people with subjective memory complaints. They collect 28 studies, around 30,000 unique individuals have with mild cognitive impairment, have without cognitive impairment, and the risk of the people who express subjective memory compliance for more than to develop Alzheimer's disease. But that is interesting results here, because approximately the 2.3% and 6.6% in these older people with subjective memory compliance progress to dementia and progress to mild cognitive impairment for years. That is important data to I use to explain you our interest to analyze and to study the population with expressed subjective memory cognitive declines. What is FACEHBI? FACEHBI is a Fundació Health Brain Initiative. It is a clinical trial. It's a clinical trial embedded in the longitudinal study about cognition, risk factors, and lifestyle in the subject with subjective cognitive decline. We are defined as a long-term observational study, even though it's only for 2 years. We have a budget to finance all this study, but we hope to find more financial to prolong this study, and it's registered like a clinical trial. And why we register like a clinical trial? Because you use a beta marker, and it's mandatory in the regulatory norms of the MMPs to register that studies, that longitudinal studies like a clinical trial, and we move on in the mark of the framework like a clinical trial. It's a single-site long-term observational study with SPED, include 200 individuals diagnosed with SCD. The site is Barcelona Alzheimer Treatment and Research Center Memory Clinic, and the duration at that moment, and we have financial for 2 years follow-ups. The general objective is to study the risk of the cognitive marker and the biomarker that better predict appearance of subsequent cognitive decline. And this study includes to know more about the phenomenology of the subjective cognitive decline, like demographic, social, personality, nature and prevalence of different cognitive symptoms, because one symptoms lead to Alzheimer's disease, and other symptoms can lead to Parkinson's disease. And that it's important to define when you design the first step of this, the FACEHBI study, the relationships between objective and subjective cognition, and also the association of SDC with different AD biomarkers. Well, the main objective is to determine better high baseline cerebral amyloid burden measured by floor beta band, FBB PET, is related to the worse the performance on the face name test during these 2 years. And the face name test is introduced by the group of Harvard from the Rice Sperling and led by Doreen Red and Rebecca Marillo, in order to detect if the performance in this test is correlated with the burden of A-beta amyloid in normal early aging patients. And this test is validated for our institution, led by Montse Alegret and their teams. The secondary objective is to determine whether the amyloid burden is related with APOE genotype, or with the plasmatic levels at the baseline and the 2 years. Also, if there are some correlations with MRI measures, or with the neuropsychological battery of Fundació and IBBACE at the baseline and the 2 years, but it's interesting for us to explore whether brief neuropsychological tests can predict accelerated cognitive impairment, because as you can see in the next slides, the battery of the neuropsychological battery to define subjective cognitive decline and to use another batteries to explore sleep disturbance, mood, apathy, depression, can to move our diagnosis and can to lead the concept of subjective compliance in different phenotypes like Alzheimer's disease or Parkinson's disease at the least. Let me show you only one thing here because it's the different from another clinical trials, and the thing is to use the memory files every day in the inclusion criteria. So that is a test. It's designed for Barbara Wilson, and it's validated in the Spanish population by the Grupo de Montejo. And you use this score for include patients with memory complaints. The other it's a normal score. It's a very standard score from my cognitive impairment and from subjective cognitive decline in MMMSs. The clinical rating scale is 0 because 0-1 with impairment of activities like living seems to be or could be included in mild cognitive decline, and FACEHBI study wants to exclude completely the mild cognitive impairment in this collection. And talk about what is the kind we engage patients for this specific study or this specific clinical trial. We have two sources to include patients. One is the protocol in our memory clinic. It represents 30%. And we have an open house initiative, and it represents 17 half of the inclusion patients. Let me to talk about from the two sources, because in the new paper he's writing for Carla de Lamour, we want to define if the population seems to be little difference, that it's referred from the GP, from the memory unit, the subjects or patients could be. It's referred from the GPS, from the Public Health Center of the Catalan government, and here it's referred from the citizens, volunteers, in an open house initiative. What about? Well, that is the normal procedure in the Fundació is the patient or the subject is arrived in our memory unit, referred for the GP. We devote two times visit from the family with a social worker, because we include social worker in other group, and later we have a standard neurological exam, the neuropsychological exam. We have a daily consensus conference in order to reach final diagnosis with, like, it's involved neurological features, neuropsychological findings, and social findings to establish a global therapeutic, pharmacological, non-pharmacological, case manage, and deliver this one to the family. That is the standard process for the diagnosis in Fundació. And for this way, by the GPs, in the last year, 2014, we have diagnosis to 257 new patients with these characteristics focused on CDR-O. That CDR 0.5, it's mild cognitive impairment, and that is the group of patients with dementia. In this cartoon, we are not defined if the phenotype of dementia could be frontal dementia, Alzheimer's dementia, Lewy body dementia, vascular dementia, and other. But here we include people who have not objective cognitive impairment defined like mild cognitive impairment. What about Open House Initiative? Open House Initiative is a real major charity from Fundació. We start this action since 2008, And we invited to the citizens of Barcelona, over 49, to attend our memory clinic for free cognitive scanning. And with this, we have designed a protocol. It takes us more or less 45 minutes. And with this initial cognitive screening, regardless the preliminary diagnostic, as you can see in the next slide, we invite to the citizens to participate in the FACEHBI or to explore in more deep the cognitive function. What is the process? The process, it's quite different from the standardized process, because social workers, they have not actions in the open house diagnosis. We explore with a neurological exam, neuropsychological battery, it's the same. We have a daily consensus to define if it's mild dementia or subjective cognitive decline, if it could be included, if it could be included in this study, we invite to the subject to participate in it. That is the difference from the normal protocol and the protocol that we use from the open house initiative. What about the open house initiative? Open house initiative is very well established, as you can see here, and just now we have a collection of data about 1,700, more or less 800 subjects with his participate in this initiative. And what is the profile of diagnosis in the open house initiative? His volunteers, citizens to Barcelona, without his bypass from the GPs and collage, and use open house initiative to detect some abnormalities in her memory, like to the prescreen, like cholesterol, glycemia, or hypertension. That is our slogan. If you test and you pay attention for the cholesterol, why not pay attention for the memory? And the more relevant questions here from the last year, is that we found an important percentage, more than 55%, it's near 35% of mild cognitive impairment only in this selection, only in this selection. And half of sample express subjective cognitive decline that we invite to be in the deep exploration to define really if can be included in FACEHBI study or not. And what is the flow chart of the FACEHBI study? Here we have a visit in the baseline. We have a visited in 1 year, the first visit, and the last visit at the moment, in the visit 2, in the 2 years, we explore neurological, neuropsychological, blood tests, MRI, FBB, and neuro-ophthalmology. Only in the first visit, in the first time, we only used neurological exploration and neuropsychology, and it's not a clonic from the baseline. More in deep, and define what we are doing in the baseline in the second year. What are you doing in the baseline and the second year? That at first, informed consent, neurological examination, and anamnesis, and anybody's battery last standard from our institution, the face name, because you introduce the face name in this, as you remember, it's the principal objective, make the correlation from the face name and burden and the load of amyloid load in the FBB, but we introduce some others tests in order to make a map of cognitive functions to relate what is happened when we have one patient, he told us about his memory, it's not working well, and sometimes it's not her memory, it's the language, or sometimes it's executive function, or sometimes it's visual perception. And if you not define very well this clinical trial and not define very well the different functions and introduce language in a specific features, at the end of this study could be in errors. And we have a blood test for analyze amyloid species, the FPV, PET, MRI, structural, resting state, DTI, because DTI seems that we believe that it's important in order to define the burden of microvascular lesions, and ophthalmology like OCT, because OCT seems to induce us that retin can to express the same atrophy from the cortical thickness in the occipital, or in the cortical thickness in my cognitive impairment, even though in Alzheimer's disease. That is our protocol. Now, what is our activity? We start the study in December, the last December. We are pre-screening 446 patients, subjects, because it's a normal person. Failure screenings only 2. And we are scheduling 126 patients. All these 126 patients, that's complete neurological, neuropsychological, blood tests, OCT, and some of them spending from MRI and FBB. We have not so much dropouts from the consent and for the impossibility to do MRI. And we, at the moment, we have active subjects around 117. A little more. 2 things. We had increased the recruitment. There was one moment we recruit 8 patients weekly, and now it's 5 patients weekly because we have some problems to acquire the product, the FEV from France and from Madrid, and we reduced inclusion patients, but more or less it's at the bad times 4, and the best time is 8 patients for each week. And if you regard here the main age, which it's young people, it's 65, it's 10 years younger than the Franceschen collection, and could be from the Vallecas collection. It's more or less 70, 75, no? I remember very well. And another good question is the education level. This pollution have a good education level. Could be for the majority of these patients come as from as a volunteers from the Open House Initiative, and these complaints don't reach the GP, and that could be the difference from the 30% of the patients through the memory clinic and the 70% of the patients through cognitive complaints. That could be the difference, but it's significant the age, and it's significant the age, it's significant education, of course the significance of MMS, it's reached to the normality. I want to talk only about the neuroimaging preliminary results, not other things, because it's impossible for us, it's imprudent, it's not conservative to talk about the results that could be modified in the last picture. But we want to talk about the results about the first 17 subjects who complete all the study, but we are focused on only in neuroimaging. And we find some results that make us some questions, provoke us some hypotheses, and I pretend that you have questions and provoke some hypotheses in this kind of sample. That is the explanation about neuroimaging statistics. statistics tool, parameters on MRI, FEV processing, DTI. I am not neuroradiologist, I am not physics. Please, if you want something, email me and somebody answered your question, because I am not in a good shape to answer questions about the neuroimaging study and analysis. But that is important. Some results. Well, as you expect, they are a good relationship with hippocampus volume and age, as we are expect. Also, it's weaker, but also with the cortex, with the cortex mean thickness and year. That it's normal, and I think that it's not question for the audience, because we expect when we have a relationship with volume and age, the relationship it's match very well, this one. In our sample, we have a low level of weight matters, lesion or microvascular lesions, and this microvascular lesion or microvascular burden don't reach more than 1 millimole. And the same appear when we study FVB. And when we study with ABB, the burden of amyloid is less, really is less. We expected this one, we expected more or less this one. It's only 4 patients have positivity in the PET imaging and branch the 6% of the our population. What is interesting here? I think that could be the most interesting picture for us, and I don't know for you, but that is not the final picture of our study. It seems in our hands or in our data set that burden, lot of amyloid is not related with age. Age is not a risk factor for the load burden in subjective cognitive decline subject. I don't know. That is the 4 results. In a small sample, please, a small sample, only 17 patients with FVB. Another thing, it's interesting thing, is when we match FVB with MRI, finding microvascular lesions and amyloid burden. And if you know, we have a box completely empty and a box completely full. What is happening with this one? Another box which express white matter lesions, microvascular lesions, or the burden of white matter lesions, and another amyloid pathology. What is happening here? Well, I'm sorry, because I señalize in my 2 minutos. Bueno, ya iré deprisa. I'm sorry. And what is happened here? Here, it's empty in our concept because we are not include MCA patients, and they are not diseased here. That is empty. It could be it's a correlation that we are included very well, because in this box there are not expression of both pathology. White matter pathology is in this box, amyloid pathology is another box, and in the full box seems that 2 biomarkers don't share in this population. This population with subjective cognitive decline don't have the 2 markers, vascular markers and E-beta marker. What that could be our hypothesis at that moment. Or no, it's not our hypothesis, our interest. Our interest is focused on this box in order to detect what is the person of these very healthy people to develop in the future Alzheimer's disease, because here they are developing Alzheimer's disease, mild cognitive impairment developing Alzheimer's disease, and they are empty because we are not include this kind of patients in this one. Rapido, quickly. That is some about the relationship with FACEHBI and DTI, and the relationships have a strong relationship in the tracts related to the corpus callosum, in the body of the corpus callosum, that you can see here, and the splenium of the corpus callosum, then you can be here. And that is the retention from amyloid burden and alterations in the tracts. And finally, and summarize a little. It's a little, it's very short summarize. Who is the parameters that we are, things that be consolidate in this study to relate to FACEHBI and tracts. That it's a good correlation with the body splenium and trends with the single line, and no relationship with the white matter regions, hippocampal volumes, or cortical mean thickness. Well, finishing my talk, the final comments, not the conclusions, final comments. SCD individuals, amyloid load, in SCD individuals, amyloid load is relatively low in our study. SCD amyloid load does not seem to be related with age. For us, that is important. With hippocampal atrophy, white matter lesions, or cortical mean thickness. CSD amyloid load is related, remember the corpus callosum, remember to the bridge disruption of white matter microstructure, especially in corpus callosum. Could be more, but we have no other results. And white matter microstructure disruption could be a very early phenomenon in the physiopathology of the CSD spectrum. And thank you for the attention. Thank you to follow me this one. That is our partners. And the team who is involved in this clinical study, people from Fundació. My thanks to Octavio, Agustín, Oscar Sotolongo, he's the physics, and Sergi Valero, he's the statistical analysis, to Hospital Clinic from Paco Lomenya, he's the principal investigator in FBB, and clinical collaboration with the Department of Neuroradiology Department with Assunta Vives and Marta Gómez, and with Marcelo Betier, who worked with us in order to define the language findings in this one, and also all the volunteers, because without volunteers, FACEHBI can exist, and all the team of Fundació ACE who allows us to work in this fascinating, exciting study. Thank you very much. Thank you very much.
Thank you very much. I'm sorry for the warning in order to finish in the scheduled time. I have time for a question.
I will take kind of my closing remarks to ask you a question. But okay, it's only a short question. Easy, very easy. Subjective cognitive decline apparently is not just so subjective, it's something real. And in this case, if we think that it's something real, my question is, do you think that this is a irreversible process, or could you do any treatment to reverse and to have again this step without problems?
It's a very good problem. No, the reversible, I don't know. No. I don't know. Because we have not the follow. But I think it's not the reversible. But the most important question is the variability in the neuropsychological and the neuroimaging features to drive, could be to the normal, I don't know. to the normal or from
Because
to the
if
pathology.
irreversible, do you think in any treatment? Any treatment to...
No, I don't think in the treatment, but other colleagues and other institutions think in the treatment in this kind of switches, like FACEHBI and Polisen. Really, the controls patients, the control switches that they won't include in for a. It could be the similar phenomenology or the phenotype at subjective cognitive complaint. And my discussion with FACEHBI is our series, our collection, is not normal because we are not included normal patients when we have in the open house said, I don't have memory problems. And this population have a subjective feeling that something was happening. And we want to determine if subjective feelings can to drive or can to be a prodromic to prodromic myocognitive impairment. Thank you.
Speakers, I think it's time to finish this session, and next coming up is our director for concluding remarks.
Okay, sorry, because we are a little out of time, and then I will be very short. I try to be 5 minutes to comment on the closing remarks. As I told you, this Congress is at its end, and probably, and I hope, that after this meeting, we have increased our knowledge on dementia, on movement disorders, and in neural muscular problems. And if we have increased our knowledge in that, it's probably due that we have excellent speakers and participants. Then I would like first to thank to, for example, one of the foreign speakers that remain here. He remained for the whole Congress, that is Professor Khachaturian, and also to Ángel Ciudad Domínguez, that is also one of the foreign speakers that was during the whole meeting. But also I would like to thank not only to the foreigners, but also to the native speakers and the participants, because the participation was also great. And I think that we can improve year by year. And now, after saying that, and to be very, very brief, if you don't mind, I will change to Spanish. Because antes de que marcharos todos a casa, quería agradecer la participación de lo que verdaderamente de los de CIBERNED. Esto es CIBERNED. Yo ahora estoy aquí, pero en pocos años o en poco tiempo estaré allí. Y entonces es una cosa de cuestión de tiempo. O sea, CIBERNED es todo. Y entonces esto yo creo que no ha salido mal. No quiero decir que ha salido excelentemente bien, pero yo creo que ha salido bastante bien porque gracias a todos, nacionales, extranjeros y sobre todo también gente de aquí, de la ciudad, y quiero agradecer a Antonia Gutiérrez por su hospitalidad, ayuda, etcétera, y porque además yo creo que tiene buena calidad de vida, que es algo que hemos estado hablando, viviendo en esta ciudad. Quisiera también agradecer a los que verdaderamente han hecho todo, de la cosa del día a día, como es a Almudena, a Sole, a Paloma, a Beatriz, a José de Arriba, que le pido disculpas porque el otro día dije José y no dije de arriba. Pues hoy lo digo 2 veces, de arriba, vamos, o sea, y por su buen hacer. A las instituciones concertadas, tanto públicas como no públicas, pues por ejemplo la Fundación CIIEN, la Fundación Reina Sofía, la Fundación ACE, con la que cada vez tenemos más interacción, y yo no sé si todavía me queda alguien, digamos, y si me queda alguien, pues por favor disculparme porque no es mi intención. Y obviamente también pues a Miguel Medina y a María Ángeles Pérez, que están ahí. Como he dicho, perdonad si me dejo a alguien, porque lo que sí debo decir es que no es difícil llevar a cabo un congreso, a pesar de lo que parece, como el que acaba ahora, y que generalmente los resultados son buenos si se tiene un buen equipo, y yo creo que hay un buen equipo. Y con eso, pues hasta el año que viene. Hasta luego.